Just to finish up the rest of the GI lecture, this is kind of one of the slides that we got up to was ulcerative colitis. Remember, there are several inflammatory diseases. Ulcerative colitis, or UC, affects usually the rectum and the sigmoid colon, but can extend the full length of the colon. So remember that ulcerative colitis, the way it's colitis, is inflammation of the colon, not necessarily of the small intestine. So keeping that straight is important. Many of these diseases will have, periodic remissions and exacerbations. If they get infections, sometimes this will flare up worse. Ulcerative colitis has this phenomenon called mucosa hyperemia, where it gets increased blood flow to the colon. It gets edematous and reddened, and has often small erosions, bleeding of the lining, and ulcers, which can cause anemia in this type patient. And so, as we talked about with GI bleeding, this is going to be in the lower part of the gut. So you're more likely to see, bright red bleeding with an ulcerative colitis than some of the other diseases we've talked about. Again, there's the picture of it and kind of what it looks like in terms of the reddened appearance and all the irritation and erosions that you see there. Symptoms that you see with UC are stool that contains blood and mucus. They have an unpleasant, urgent need to defecate, and sometimes the pain is relieved after having a bowel movement. They're usually kind of have a cyst, very listless, will have malaise, meaning that they're just not very much energy level to take care of anything for themselves. If you know that you're going to have diarrhea and pain like this with bowel movements or prior to, you don't tend to want to eat very much. Again, you can have some anemia from the blood loss, from the erosions, and you often have weight loss too because you're having quite a bit of diarrhea. The diarrhea can also lead to hypokalemia, and this is even worse in elderly patients. And they can get dehydrated and have fevers because of that diarrhea frequency, and the fever can come from more the infectious inflammatory process. Some of the labs that they get, of course, you're looking for things like hemoglobin hematocrit related to blood loss potential or anemia potential. Labs for C-reactive protein and ESR elevate when there's an active inflammation going on. So often those will be done as blood work just to see. If those come back positive for inflammation, then they typically are considered that they're in a exacerbation. Again, you're looking for electrolytes like sodium, potassium chloride to be low because of the frequent diarrhea. And they also may be losing protein in their stool, so their albumin could be low as well. Imaging, there's a few tests that are done to kind of look at the lower bowel. Colonoscopy is usually done to diagnose, but as you can imagine, it's difficult for the patients to complete the bowel prep to really clean them out because of how severe of the reaction is to having constant diarrhea stools to clean their colon out. CTs can be done as well as barium enemas to look at the colon and see the condition of it. The goal for UC is to reduce the diarrhea stools to a manageable level. You don't want this patient to be in the situation like I described with my friend's mother who had the cancer that was kind of strangulating around the bowel. So you want to monitor the weight of the patient in an ongoing way to make sure they're not losing too much weight from flare-ups. They can be on anti-inflammatory meds, particularly glucocorticoids, but you have to watch for the long-term side effects, so make sure that you know what those might be. And then immunomodulators are drugs that can be given. They don't really help the disease as much as potentiate the steroid response. So sometimes you see those given in combination but not singly. And then there is a complication of UC called toxic megacolon, where the colon just becomes massively inflamed and enlarged to the point where toxins escape into the body. And so Remicade is a drug that can be given for that particular complication, along with surgery that we'll talk about. Nutrition for these patients, when they're hospitalized, you want to keep them NPO so that their bowel has time to rest. Often they may be put on what's called total parenteral nutrition, which is IV nutrition that tends to have a much higher glucose content, along with very specific prescription from a dietitian in terms of the types of elements and vitamins, as well as all the electrolyte percentages or components that is required. It is standard of care to monitor their glucose every 6 hours while they're on this because of the higher glucose content in the IV. And often they'll be on sliding scale insulin for coverage if it spikes their blood sugar up too high while they're on it. Things to avoid: caffeine and alcohol can cause cramping, so you want to avoid that. With this particular disease, you want to avoid high fiber foods and vegetables because they cause the patient to have symptoms that is worse. Lactose containing foods like milk products tend to cause more diarrhea with some of these patients. And then other GI stimulants, some of which we've already talked about, should be avoided as well. Some people will have complementary therapy just to try to cope with and handle some of the symptoms also. Selenium, flaxseed, vitamin C. Some people will have hypnosis, take yoga, or have found acupuncture or biofeedback helpful. If they do develop a toxic megacolon, they may have hemorrhage and complications that require them to have a temporary ileostomy, and in that case they may take the affected colon segment out and just create a period of time where their bowel evacuates through an ileostomy, and then at some point several months later determine whether they're capable of having a revision done to attach the colon back to the rectum to have bowel movements in a normal way. Make sure that you review Table 57.4 on page 1174 in your textbook. It kind of goes into more of a detail related to complications and causes. Some of the key things that you see with UC are hemorrhage can occur, if they have quite a bit of bleeding. They can form abscesses or pockets of infection in the colon. Again, toxic megacolon. They can have non-mechanical bowel obstruction, meaning that the bowels just in one area don't move or don't have any mobility because of the complications. They can have fistulas, which we're going to see some pictures of here soon. And patients who have ulcerative colitis are at a very high risk for developing colorectal cancer later in life. Now moving on to Crohn's disease. Again, it's the second chronic inflammatory disease of the small intestine, the colon, or both. So the difference with Crohn's disease is it can affect the small intestine as well as the colon. So it can be anywhere in that 30 feet of intestinal tract, like we talked about, from the mouth to the anus. It has an unknown cause. It is slowly progressive. It's very unpredictable. One thing that is characteristic of Crohn's disease and none of the other diseases of the intestines is what they call skip lesions, meaning that they may have normal intestine, then they may skip and have a an inflamed area, then they'll have normal intestine area again, and then another skip. So it kind of is bad section, good section, bad section, good section, and they call that skip lesions. They also can develop strictures, very deep ulcerations, and a thickened bowel wall that's called a cobblestone bowel wall. And we'll see a picture of that in a minute. And because these little deep crevices and ulcerations, there is really areas where fistulas can occur between parts of the colon and create an area where one intestine is kind of communicating with another area of it, and develop some draining areas and open intestinal areas. Again, it's recurrent with remissions and exacerbations, just like UC. It is made worse when the person has bacterial infections, and 1 million people in the U.S. have the disease, so it's fairly common. This is the picture of the Crohn's disease affected intestine. You can see that cobblestone look that's very characteristic. And the colon in this area, you can see how in those crevices things can get stuck. Pockets of fluid could form fairly easily if it expanded in and around that. Crohn's disease patients will have abdominal distension as a normal for their disease. Their bowel sounds may be absent when they're having severe inflammation. They also may have a very characteristic high-pitched rushing sound in their bowels, anywhere where there's a narrowed bowel loop. So when you're listening to Crohn's and listening at bowel sounds, if you hear what is a very high-pitched rushing sound, like squeaking sort of, that is characteristic of Crohn's disease and not in some of the other diseases. They of course will also have diarrhea, but it will have a fatty content to it called steatorrhea. They often have abdominal pain that is usually constant around the umbilicus before and after bowel movements. So their pain is more continuous than ulcerative colitis is more right when they're getting ready to defecate. They tend to run a low grade fever when they're having inflammation. They have a much higher fever when there's fistulas or abscesses in terms of big pockets of infection are present. They can have weight loss. Because the small intestine is affected with Crohn's disease instead of ulcerative colitis, there is much more risk of malabsorption of nutrients with Crohn's disease and anorexia, also because of the other reasons we've already talked about. They frequently have electrolyte imbalances because the whole GI tract can be affected. And they can have more of a slow bleeding in their stool because, remember, their irritation skips around, so it can be in the small intestine or the colon. So they can have anemia, but you might not see bright red blood. Sometimes you might see dark stool that's been in there for a while because it's traveled through a distance of the small bowel before getting to the colon. Again, treatments, monitoring labs just like with some of the other things, looking for inflammation with lab work. X-rays can show some of this information because the colon looks very different. MRI can be done to look at bowel activity. CT scans and ultrasounds are pretty common. Meds are similar. You're trying to control symptoms. Some other drugs are also given to suppress the immune activity of the disease, to decrease the response to the inflammation. And some of these will suppress the immune system. So as we mentioned in class, These patients have to be watched for, getting closer around other people that have germs, because the treatment itself to control the inflammation also